Hi, my name is Dr. Shirish Gadgeel. I'm Chief of Division of Hematology Oncology at Henry Ford Cancer Institute, Henry Ford Health in Detroit, Michigan. And today I'm going to be discussing two studies. One, the ALKOVE-1 trial evaluating, it's a phase 1-2 trial of NVL-655. This is an ALK TKI, and it was developed with three specific features. It's a drug that can target, at least in preclinical models, tumors with compound ALK mutations that can emerge when tumors become resistant to second and third generation ALK TKIs like alectinib, brigatinib, and lorlatinib. It was also developed with it was also developed so that the drug would have a high degree of brain penetrance to manage brain metastases. And finally, it was developed with the goal of avoiding a TRK inhibition-related adverse events. So lorlatinib, though a very effective ALK inhibitor, does have certain unique side effects, and many of them are related to its TRK inhibition properties. And so this drug was developed with an intention to avoid TRK inhibition. So it can target ALK effectively, but it can target compound ALK mutations, is a brain-penetrant ALK TKI, and it avoids TRK inhibition. So this drug was studied in a phase 1-2 trial, and this was primarily conducted in patients who were previously treated with ALK TKIs as well as chemotherapy, and they could have had any number of ALK TKIs. And overall, this drug demonstrated a response of 38% in this highly refractory patient population. But what was interesting is that the drug was quite active in patients who had the G1202R ALK mutation with a response rate of about 70%, as well as in patients who had compound ALK mutations where the response rates were anywhere from 54 to 65%. And if you looked at any patient who had received lorlatinib, which is considered the most effective ALK inhibitor, the response rates in all patients who had received prior ALK inhibitor, the response rate had received lorlatinib rather, the response rate was 35%. The drug was also reasonably well tolerated with liver function tests, AST, ALT elevation as being the most common adverse event. Despite this, very few patients discontinued the drug related to adverse events. It was only 2% of the patients discontinued the drug because of adverse events, and then about 15% of the patients had dose reduction. Another interesting data set was that the drug did demonstrate intracranial response, including in patients who had received prior lorlatinib. And so this drug potentially could be effective in patients who have progression in the brain following lorlatinib treatment. So these data clearly demonstrate that this drug can be effective in patients who have had multiple prior TKIs, including lorlatinib, appears to be well tolerated, doesn't appear to have the adverse events seen with lorlatinib related to the TRK inhibition. This drug is now going to be evaluated in other studies, including possibly in a frontline trial to see if this drug provides better benefit than what we see with currently available ALK inhibitors. The second trial that I had the privilege of being part of and was presented by Dr. Benjamin Bessie was the ARROS-1 trial. This evaluated the drug called now zidesamtinib. It is ZIDESAMTINIB I still am going to call it NVL-520, a much easier way to remember the drug. This is a ROS1 inhibitor, and this drug was evaluated in patients who had previously received ROS1 inhibitors. And again, this drug, like NVL-655, was developed with the intent of being potent inhibitor of ROS1, have brain penetrance as a property, as well as avoid TRK inhibition, which also is associated with toxicities with drugs like repotrectinib and entrectinib. And so the drug was developed with the intention of avoiding TRK inhibition so that it would have a better adverse effect profile. So this drug also in patients who had received prior ROS1 TKI, but were repotrectinib naive. Repotrectinib naive was 51%, whereas patients who had received prior repotrectinib, the response rate was 38%. And this drug also demonstrated CNS activity with a response rate of 50%, though the evaluable number of patients was only 8. But at least the initial results demonstrate that the drug may have intracranial efficacy. This drug was also quite well tolerated. There was peripheral edema seen. There was also liver enzyme elevation observed with this drug, but the rates were quite low. Most of them were grade 1 or 2, and the rates were about 10 to 15%. There were no patients who discontinued the drug because of adverse events, and only 8% of the patients needed dose reduction because of toxicity. So this drug is also going to be further evaluated in this population, as well as now in TKI naive ROS1 positive advanced non-small cell lung cancer patients. And these further studies will truly define the utility of this drug in management of ROS1 positive patients. So these were two interesting trials that I had the privilege of being involved with, and just is part of this continuum of advances that we have been observing in the field of thoracic oncology, specifically lung cancer, where these advances have made a very meaningful difference in the treatment of lung cancer patients. And now, as somebody who has worked, who has taken care of lung cancer patients for the last 23 years, I have patients who are alive even after stage 4 lung cancer diagnosis, even 12, 13, 14 years. And we feel we are only at the beginning, and we hope that these advances lead to even better outcomes of our patients and in a higher proportion of patients.